I'm the Director of Economic Affairs for the Israeli Consulate here in Miami. And first of all, I'd like to thank everyone for coming out today, giving us this hour of your time. And I'm actually just going to start this up really quickly with a personal note. My father came down with COVID-19 last month. He spent 10 days in the ICU, and he's fine now, recovering at home. And of course, I wouldn't wish an experience like that on anyone. But one of the things that was really interesting was that in all of my conversations with his doctors, nurses, and case managers, I learned so much more about this virus and how the hospitals are treating it that I wouldn't have gotten from, just from the news. And that was really the inspiration for this webinar. So everybody should have the opportunity to hear firsthand about the incredible job that our hospitals are doing right now. And we often don't, because the people who can tell those stories are too busy saving the lives of people like my father. That's why I'm so appreciative of Dr. Abbo and Professor Regev for taking just a little time out of their incredibly busy schedule to join us today. So thank you both. Couple very quick housekeeping notes before we get started. First of all, unless you are one of the speakers, please keep yourself mute throughout the presentation. But please do use the chat function to ask any questions you have for our speakers or to interact with other participants. Secondly, shortly after this webinar ends, all the attendees will receive an email with a recording of this entire webinar and the presentations from Early Sense and AnyVision, and also a very brief survey. We'd love to get your feedback on what you liked and didn't like. And also, if you have a great idea for a webinar that can help build bridges between Israel and Florida, we'd love to partner with you. We're gonna keep doing these for as long as people are stuck inside their homes. So I'll also post my email in the chat if you wanna follow up with me directly. So speaking of follow-ups, I'd like to very briefly introduce my colleague from Israel's Economic Mission to New York, Josh Berliner. Josh, are you there?
Yeah, can you hear me?
Yeah.
Can you hear me?
Yeah, I can hear you. Go ahead. Oh, wait, now you're muted.
So now?
Yes, go ahead.
Greg? Okay, so everybody, thanks to the organizers. It's an honor to be here with the Consul General and everyone who came together today. I'm representing the Government of Israel Economic Mission to the Eastern U.S. We're based in New York City. My boss is Zeno Nalroy, the local commercial attaché. Our objective is to help Israeli companies find strategic partners, distribution channels, and investors in the local market. And we also want to help local organizations such as Jackson Health and the entire Miami healthcare ecosystem find innovation partners and investment opportunities in Israel. We're like a free scouting service for the local ecosystem. In addition to supporting today's event, I want to make sure that you all knew about two future opportunities. Number one, about the BIRD Foundation. BIRD stands for Bilateral Industrial Research and Development. It's a bilateral program supported by both the US and the Israeli government since the 1970s and provides funding for any commercializable R&D joint venture between the US and Israeli companies. If you have a great idea and it's innovation and it has commercial potential and you can find a partner in Israel, you guys can unlock the funding to make it happen. And we'll be happy to help you do that. And it's a conditional loan or a grant, and they don't take any equity. And the second opportunity is on Tuesday, May 26th. There'll be another global webinar organized with Clalit Health, which is the second largest HMO in the world after Kaiser, and it's the largest in Israel. And that will also feature about how the Israeli ecosystem, which is almost 100% open today after COVID, and innovation are teaming up to combat the pandemic. Thank you so much.
Thanks, Josh. And now I would like to introduce the Interim Consul General from Israel in Miami, Shlomit Sufa. Consul General Sufa just arrived a couple weeks ago, and we're very appreciative of her leadership during this difficult time. So, Consul General, are you there?
Yes, I'm here.
I can hear you. You're fine.
Okay. Thank you very much. Thank you, Greg, very much for, sorry?
Yes, we can hear you.
Okay, great. So hello, everybody, and good morning. Thank you very much for joining us. Thank you very much, Greg, for the introduction and for your excellent work coordinating this webinar. As Greg said, I'm here only temporarily, so I'm very honored to be able to join these events, especially these days when it is not possible yet to meet people in person. It is also beneficial that when we hold these kind of events, webinars and Zoom conversations and conferences, more people actually can join because they are not limited by time and traveling. So this webinar is an excellent opportunity to present both of two of our main goals working here at Florida in Miami, in the Consulate. One is to build bridges between Israel and Florida. And we do that today by showcasing the work of two wonderful hospitals and their fight against this pandemic. And we hope that this will lead to further cooperation and future partnerships. The second goal that we want to demonstrate today is actually Israel's agenda to help and support and to reach out whenever there's people in need, be it on, on natural disasters, be it on a world pandemic, be it on any other kind of need. Israel is working to alleviate the suffering, and we are happy to demonstrate today some of the cutting edge and innovative technologies that we use and develop to help the global fight against the pandemic, and especially in Florida. And I want just to say thank you very much to our many partners today and the very good people who did a very good job in preparing this, and especially to Yair Itzhar of Sheba, who helped arrange Professor Regev's presentation and line up with the two Israeli companies that we will be presenting today. I want to thank Matthew Pinzer of Jackson Health, who performed a very similar function vis-a-vis Dr. Abbo. I want to thank Inon Elroy and Josh Berliner of the Israeli Economic Mission in New York, and the Miami-Dade Beacon Council, and in particular, of course, Sam Blatt and Richard Bookman of the Life Science and Healthcare Committee. And I would like at this point to introduce our co-host for this event, the CEO of the Beacon Council, Mr. Michael Finney. Thank you.
Thank you, Consul General, and welcome to Miami. And also, Greg, thank you for organizing the entire event. I thought I'd start off by just letting you all know how incredible the advice and counsel I think this community has received from Dr. Abbo has been over the past several weeks. I've had a chance to participate in a number of the reopening task force meetings that Mayor Jimenez organized and his team. And Dr. Abbo has been a participant in a lot of those. And it's just the advice and counsel about how to do this right is absolutely incredible. So we very much appreciate that, and I appreciate the opportunity to be involved. I thought that was a good way to open from a Beacon Council perspective, so you get an idea of the work that we've been doing over the past few months. It really has been trying to figure out how to best help companies here in Miami-Dade that are looking to maintain their existing business profiles and perhaps expand those as we start to come out of this crisis. And so a lot of the work has been behind the scenes, working to get prepared. And now that we've started to move into an opening mode, to begin the process of helping companies as they look for talent, look for reestablishing business relationships, look for funding that they need in order to get themselves back up and running, we'll be playing a central role in helping to facilitate all of that. So we're excited about it. Our organization, we serve as the official economic development partner for Miami-Dade County, and we work with virtually any and every company and organization in the region that's focused on a vibrant economic future for this region via business development. I also, on a personal level, have worked extensively in Israel with Israeli companies during my prior life in New York State and in Michigan, and now also here in Miami-Dade. I've worked with the Bird Foundation on a number of occasions on projects, as well as various institutions in the state of Israel, as we look to facilitate innovation, transfer of innovations, commercialization of innovations, et cetera. And so I'm really excited about this opportunity and the work that you're doing to help drive innovations here in Miami and vice versa in Israel. We know that COVID-19 is driving a lot of innovation that I think has a lot of commercial potential. And we're working through the Life Sciences and Healthcare Committee under the leadership of Dr. Bookman and Matt Pinzer and others to really try and maximize the potential that exists. And so we as an organization just look forward to working with all of you. We very much appreciate Greg organizing this, Consul General. We appreciate you being available, and welcome to Miami.
So with that, Greg, it's all right. I'll just take the feed from Mike. Mike, thank you for those comments. My name's Richard Bookman. I'm a faculty member at the University of Miami Miller School of Medicine, and I'll be moderating today. In order to make the best use of everyone's time, I really would like to just jump into it with Dr. Abbo and Dr. Regev. I had a chance to talk with the two of them, and what I'd really like to do with Dr. Abbo and Dr. Regev is have you listen in on a conversation between two physician experts who have been at the front lines of this pandemic, you know, from the very beginning, and listen to a little bit of the way in which it played out at Jackson Health System and at Sheba Medical Center. If we could, maybe we could start with Dr. Regev, if you're ready. Just maybe help us all understand a little bit about Sheba Medical Center and talk us through, you know, the last few months dealing with COVID-19 at your medical center.
Yes, sure. So at Sheba Medical Center is the largest tertiary hospital in Israel with 1,600 beds, some for rehabilitation and mostly acute care. And we have currently, the situation in Israel is that we have nearly 17,000 cases of COVID-19. The death rate is around 200, nearly 280 cases. So that is relatively low. What else? The other thing we had, if we're looking at the epidemic curve, the highest, the peak, I would say, was around 750 cases per day. I'm not sure how much it was in Florida. And that was around the beginning of April. So our first case was actually on the 23rd of February. And we had a few arrivals from the Diamond Princess a couple of days before, but the first case was an imported case from Italy. And since then, it took, I would say, about 3 weeks before we started to see the emergence of the epidemic. Maybe here we'll stop, and before I'll say a few points about the keys that I believe are the keys to success. Some of them, some of the innovations we had, maybe we'll sort of compare and see what's happening in Florida or in Jackson. Does that make sense?
Sure, yes, please, go ahead.
So, Dr. Abbo?
Participate in this meeting today. Some of the differences that exist is that, of course, Florida is much larger than Israel. And we have a very large population and density of population. So in the United States, we started preparing for the pandemic, at least in our health system, also since January, when we heard late in December that there was a novel virus causing acute respiratory distress in China, we started triaging at all our entry points. And Jackson Health System is a large health system. We have our main hospital, similar to Sheba. We have 1,500 beds, but we have 4 acute care hospitals. We have a children's hospital, 2 community hospitals, and the main hospital. We also have a mental health hospital. So overall, there are over 2,500 beds in all these facilities. We also provide the care for 2 long-term care facilities in our health system. And we also oversee the infection control and the health services for 4 of the Miami-Dade County jails, which any given day have between 4,000 and 5,000 inmates. In addition to that, we have 5 urgent care centers with the University of Miami and hundreds of clinics. So we are a mini ecosystem within Miami-Dade County that has a population of like 2.4 million people. In the United States, as of today, we've had over 1.58 million cases confirmed of COVID. In Florida, we have tested over almost 800,000 people as of this morning, and we have 47,471 positive cases. Just in Miami-Dade County, we've had around 16,000 cases and 589 deaths. So Miami-Dade County has 34% of the cases in Florida and about 28% of the deaths. Now, our health system is the largest county hospital. We serve everyone. We don't deny care to anyone, regardless of the opportunity to pay. We take care of private and public patients. So I just want you to understand the population that we serve is also the immigrants, the uninsured, very sick people. We do transplants, we do trauma, so a lot of patients. We started preparing very early, like in Israel, and unfortunately, we don't have the same support at the country level of the major lockdown that Israel did very early on. Our lockdown started around March, but we also started seeing our first cases around the 2nd week of March. And we started already preparing since January. We have made sure we had enough supplies for healthcare workers. We have not faced a shortage of supplies like other parts of the United States, because of prolonged planning to ensure that we had protocols in place for safety of our patients, our healthcare workers, and also some luck that overall in Florida, we have not been hit as bad as New York or other parts of the United States.
Thanks, Dr. Abbo. So one of the things that we talked about a little bit earlier, and I just wanted to ask the 2 of you to sort of go back over this. You're back there in January, February, maybe just seeing your first case, et cetera, but you're facing the unknown, right? You have no idea how do you think about preparing the healthcare workforce for the unknown? And we harked back to the early days of HIV and AIDS, but here we are again. You have no idea what's coming. You don't know if respiratory distress is, et cetera. So maybe you could each talk a little bit about, as physicians facing the unknown, how you prepare your teams, and as much intellectually and scientifically as emotionally.
Yeah, so indeed, I agree. That was probably the largest challenge that we had, the fact that so many unknowns, and we did have a problem with enough equipment, PPE equipment, for example, of course, other stuff as well. And indeed, at sometime middle January, we already understood that, there's this pandemic, it's gonna hit sometime. And we were very much busy into how do we prepare for this? And I think that one of the things we very early understood is that we have to have the healthcare workers feel safe enough so they can treat the patients. And it was something in a way, against our DNA. The first thing as physicians we care about is the patients. Typically, before we think about ourselves, we think about the patients. Here we understood that mainly, again, me as responsible for the infection control, that we have to take care of the healthcare workers. If we don't let them feel safe enough, the treatment of the patients will really be not the best. And so we had sort of three aims that we had all the time, thinking and concentrating on, focusing on. One is that we separate and we have early triage to identify the patients at risk so that we can separate them from the other patients, and by that ensure the operational continuity of the rest of the hospital. And as I said, the primary aim was really to have the healthcare workers feel safe and protected. And the first thing we did was build a full department, which was outside about 2 kilometers, which is 1-point-something miles out of the hospital. And that was a department specifically just for COVID patients. Before that, of course, we treated the ER, so that would also be separate. And I think that was really one of the main things that helped us with this challenge.
And sorry, Dr. Regev, this separate facility was set up like an ICU with ventilators, or it was really just a set of beds?
The initial one was just a set of beds. It was 30 beds, a full department with separate rooms, with a very small ICU in that department for 4 or 5 beds. When we started getting the patients, immediately we transformed the parking lot, a huge parking lot, into a ICCU, we called it, Intensive Corona Care Unit, which could compensate something like altogether, it was over 100 patients. Eventually, we had nearly 30 patients in that facility, in the ICCU. Right. Altogether, I would just say another thing that we have discussed earlier, Dr. Abbo and myself, was the early lockdown that Israel had. First of all, it was the travel, not lockdown, but just travel closure of the country, so that initially just people from China and then the Far East and eventually the rest of the world slowly. And that was pretty early. So I think that really helped to control the pandemic. Currently, I would just say is that we have between 10 to 20 something cases per day currently. So right now we're in good shape.
Dr. Abbo?
I echo everything that Dr. Regev mentioned, except we didn't have a facility outside of our health system. But I want to, for those who are not in the medical field, when you're facing the unknown, what do? One, you have to follow your instincts. You have to lead in a crisis. It's like you start a war, you feel like you're in a war. You don't know where the attack is going to come, but you have to prepare from all fronts and prepare your army to be ready for the attack. So that's what we felt. We felt like we were preparing for a war and a hurricane. It was a little bit like a mystery movie, like that something is going to happen anytime and you don't know when. So there were 5 things that I think were very important for us as we were preparing. One is you have to look at what you know from other coronaviruses. We know about SARS, we know about MERS, we faced Zika, we faced Ebola. So we had to gain our knowledge. How have we faced other pandemics in our health system, and what have we learned? What have we done right, and what have we done wrong, so we don't make the same mistakes? So we aligned our leadership team that was multidisciplinary, and everyone was seeing things from a different angle. So we had procurement, looking at the supply chain. Do we have enough ventilators? Do I have enough masks? What are the other things, medications? What are the things that we haven't thought that we may need? Maybe we need to start purchasing them in advance in case there is a shortage. We started looking at, the second thing was protocols. How do we standardize that everyone hears the same thing? Things change very rapidly, but if we have a protocol, we can educate everyone on the same protocol, whether you practice 10 miles or X number of miles away from the main hospital, or you're working in the nursing home, everyone should follow the same guidelines. So it was very clear. We also created communication platforms to disseminate the information. We over-communicated. The worst thing that can happen when people are scared. They start creating their own theories, and that creates more panic. So we had to control the internal communication and the external communication, going to television, to radio, to the news stations, press conferences, explaining to the general public what could we expect, but also internally to our workforce. What is our plan? How are we protecting you? We created websites, we created apps, we created email communications on a daily basis, and the leadership team was meeting twice a day because the information was changing so rapidly. If we met in the morning, we wanted in the afternoon to know if there were any updates or things that we needed to know. For example, initially it was just travelers from China, then travelers from other parts of Asia, then travelers from Europe. So our screening questions had to change to the point that anyone who lives in Miami, now it's at risk. So those are some examples of how the protocols have changed. We also had a lot of work in our testing. The testing capacity in the United States at the beginning was horrific. We had no available ability to test. The United States decided to create their own test. They didn't go with the rest of the world. And then there were some flaws. They had to withdraw the test. We were having to send every test to a national center through the Florida Department of Health, and we had to make phone calls for 6 hours for them to approve it. So one of our priorities early in March was we need to ramp up our testing capacity with commercial labs, our internal labs. So initially it was taking up to 1 to 2 weeks to get results, which creates a lot of anxiety, and we could only test a select number of patients with symptoms. And now we're going the other way. We're testing everyone upon admission to the hospital with or without symptoms. That allows us to determine if somebody is asymptomatic, and we can put all the infection control precautions to avoid transmission. The fourth thing is contact tracing. As you have to test more people in the community and in the hospital, if somebody is exposed, you want to know who else was exposed to that person so we can stop the chain of transmission. And it's very important. And in Israel, they've done a terrific job in that. And I think we have followed that model. And then number 5 is when you're preparing, also, you don't know how this virus is transmitted. So you err on the side of overprotection, quarantining longer than usual. And I think the lockdowns, the quarantine, stopping visitors from hospitals have really helped us control the number of people that circulate in the city and are transmitting this to each other to avoid the collapse of the health system.
Fantastic, thanks, Dr. Abbo. And I know that you have another commitment coming up soon. So let me just shift a little bit of focus towards innovation. But let's start with you, Dr. Abbo, and then we'll go to Dr. Regev. And this is partly triggered by a question from the participants. So when you think back over the last 4 or 5 months, either are there some innovations that were made during this process to address the challenges, or are there some innovations, oh boy, now I see this challenge, if only we had a certain widget, a certain app, a certain technique, a certain instrument, just sort of the role of innovation, how it either helped you with this or how it might have helped you, and some ideas going forward.
So I think the innovations that have helped us that are very different than 100 years ago with the flu pandemic is one, telecommunications. Telemedicine, the capacity to communicate with the patients, with the providers, even when the patient is hospitalized in the room, the nurse and the physician can communicate very quickly via FaceTime with the patient and check how you're doing to avoid exposure of the healthcare worker. That has been a big innovation. The use of technology and the sharing of knowledge. There are papers published every minute. So sharing rapid information has been phenomenal. We have webinars that are almost daily and weekly with multiple countries where people just jump on a Zoom and we're able to share the experience from Israel, from Italy, from China, and from the US. In 45 minutes, you can educate hundreds of doctors in what is happening. And that has really been key in saving lives. There have been innovations also in the testing capacity, laboratory platforms, the collaborations that have occurred have been terrific, and innovations now coming up with new treatments that I think are helping on that arena as well. Other innovations, I think the people are working on developing PAPRs, which are protective, how do I simplify this? It's sort of a motorized airway device, so people can go without wearing a mask that it's tight on your face and you can operate, but they have been existing for many years, but now people are trying to come up with how can a surgeon who has to do a 10-hour surgery go comfortably and perform that surgery in someone with COVID? Because it's not just people with pneumonia that we're dealing now. People with COVID are coming with cancer and with other problems. So those are innovations that are happening right now. Some Israeli companies are working on that as well. And then the diagnostic capacity to Uber this, right? So people can go and get tested at home or delivering the kit so you can test yourself, but we need highly reliable platforms that are cheap, that can be adopted everywhere so people can know, oh, I'm infected, let me protect everyone else. Those are just some of the highlights. I'm gonna let Dr. Regev discuss the great work that they're doing in Israel.
Thanks, Dr. Abbo.
Yeah, so indeed, there are so many innovations currently running around that I'll just mention a few of them. And again, what have we focused on? So one thing, and I won't elaborate on that too much because Dr. Abbo actually said, and that's again, how do we protect healthcare workers using distancing, and that is using telemedicine. And we've used a lot of technologies in that, starting from just using Zoom or Zoom-like technologies, but also at the TITO, which I don't know if you know, but that's incredible. Early Sense, which I think you'll hear about later, so I won't mention that further. And again, it was amazing for me to see that actually with distance, you can be intimate with the patient and actually treat him and talk to them. We had also group conversations, and it was on one hand with the milder patients, but also at the ICU, we had a robot that would come and we could see the monitor very closely. So despite the fact that there was maybe one nurse inside the area of the ICU, the other people were from the control room and could really see and monitor the patient very closely. Another thing we had, one of the focuses is how do we do the contact tracing? How do we identify who was exposed? And one of the technologies there was AnyVision, which again, I think you'll hear more about, which is using facial recognition. And instead of, or in addition, it was not instead of, but really in addition to nurses going and asking exactly who was exposed. And a lot of people don't remember who they were with. Was I with a mask or not? So we used the cameras, which are anyway put in the hospital, and actually the AnyVision could identify, here is that patient, exactly where he was, the patient or the healthcare worker who was identified as a positive COVID patient eventually, and see whether he was with a mask, who was nearby, and that was helpful in contact tracing.
Fantastic, thank you. So let me just, because I know Dr. Abbo is going to have to leave shortly, just a question from the participants for each of you, and then maybe Dr. Abbo could go first. How are you thinking about a possible second wave of the pandemic, and in particular how that might intersect with a regular flu season come fall and winter? So Dr. Abbo?
Those are all excellent questions. So the first thing is there will be a second pandemic wave. The question is when, and nobody knows. There are different predictive models, and I think one, they depend on the human behavior. And it's very, very hard to change human behaviors, as everybody knows, to quit smoking or to change your loved one. It's very hard. After 100 years, people have been behaving on a certain way. You start opening the cities. If people don't keep the social distance and they become overconfident, we will have a second wave sooner than we would like to have. I would love to have a second wave late in the winter because we expect by then we will have a vaccine or more than one vaccine. We will have better understanding of the transmission of this disease and for how long people actually remain infectious and can transmit the infection, if we develop or not immunity, and what, for all the treatments that we're doing, we will know better in the winter what really worked and what has not worked. So that would be ideal. But I don't have a crystal ball to tell you it's going to be in a month or in 3 months. I think we need to be prepared as the second wave can come any time. And there's some models that show that this can go as long as 2 years. I hope we're not in that route. I do hope that people learn from our mistakes and that people continue to keep social distancing and use the mask and wash their hands and really perform the behaviors that we need to keep until we have immunity and until we have a vaccine.
Thanks, Dr. Abbo. I appreciate that. And Dr. Regev, to you on this second wave
Yes.
question.
Yeah, so I totally agree. There will be a second wave. The question is when. I have to say that I'm relatively surprised in Israel that we are still continuously now for, I think, already 3 or 4 weeks, seeing very low rates. Again, as I said, 10 to 30 cases per day, not more than that. So it really went down fast.
Sorry, that's
Maybe
countrywide.
it's the heat. The heat
Sorry,
might play a role. And
Dr. Regev, that number is countrywide. You're not talking about Sheba Medical Center. You're talking about
country-wise. Yes,
right.
Yes, country-wise, and Israel is a nearly 9 million population, so it's very, very good right now. The one problem is that as it becomes so good, people start, taking off their masks, being in crowds again, while we still have limitations from the MOH. Not everybody is now complying. And I fear that as, we get people feel more safe, maybe the heat does play a more major role than I expected, I have to say. And hopefully, I'm hoping that maybe we will see the second wave only in winter or maybe fall time when the temperatures start getting low again. But obviously, I agree, we don't know and we have to be prepared. One other thing, maybe in the innovation part, I'll say is that we are hoping to be able also to detect. Of course, we're all waiting for the vaccine. I mean, that will definitely put an end to the pandemic if we get a good vaccine. But if not, if we succeed to identify and detect patients sooner than later, and if we have a very good sensitive method of detecting people, even if it's not as specific, but we can say, okay, you're not allowed on the airplane or you can't go into the shopping center because you might be at risk according to our test, that would be something which could be very helpful. And currently we're working on one other innovation is a nanoscent, which is a diagnostic technology based on scent, on volatile organic compounds that you actually just breathe into it. And within 30 seconds, we're supposed to be able to say whether the patient is suspected of being COVID or not. Again, it's just in the beginning and in the really preliminary stages. So I'm not sure it will be ready by this winter. And that's why I'm hoping to, get the next wave as late as possible. But I agree, we have to be prepared any time now.
Fantastic. Thank you both so much. So at this point, we wanted to switch focus a little bit and hear from 2 Israeli-based innovators. I'm hoping, Dr. Regev, that you can hang around and join the commentary and discussion of those companies' efforts. Dr. Abbo, I know that Mr. Migoya called your presence and
yeah, I need to go. I'm running late, but I want to thank Dr. Bookman for moderating. Dr. Regev, it's been a pleasure to have this conversation again with you. I look forward to great collaborations between Israel and Miami through the Chamber of Commerce and our hospitals. We have, our heart is with Israel, and we really thank everyone for inviting us to participate today.
And Dr. Abbo, I am sure I speak for all the participants in saying that you and Dr. Regev could just keep going for hours and we would all be locked into your every thought, every word. So thank you, Dr. Abbo, for your contribution this morning.
Thank you.
So,
I will also have to leave in about 10 minutes, so okay. I'm already
okay. All right. As long as you can, Dr. Regev. Thank you. And same comment that it's so interesting, and you help us get insight into the front lines in a quite unique way that CNN doesn't provide. So thank you.
Can I ask Dr. Regev a question?
Hi, Enrique. How are you?
Hello. This is actually important because all that's been discussed here is nothing that really works other than social distancing. Dr. Regev, in Israel, they have a nanotechnology spray with copper and zinc, which is used in the food production plants. And it works against herpes virus, and it's well known that it reduces, and herpes virus is even a much more stronger virus than the corona. have you implemented the coding that's being used in Israel in food plants to the hospital yet to reduce viral spread as well as bacterial spread? And the second question is, so have you used that yet? And if you haven't, why hasn't the government and the hospitals looked at this when it works in the food plants?
So I'm not sure what exactly you're referring to, but we do have a few things that we have incorporated, and that was a while ago, irrelevant to the COVID pandemic, and that's we have copper incorporated in a few things like how do you say, the separators between one patient to another, and things like that. Some of the materials that have it inside, but not something very widespread, I would say.
Well, I would recommend that you look into this because it's a spray that lasts 1 year. They're using it in all the food plants and in multiple food plants in Israel. It's already on the market, and it is an Israeli company. And I've asked our hospital, Jackson Memorial, to look into it so that we can spray our ICUs, our floors, all over the hospital because it does prevent both bacteria and viruses from spreading into the surfaces. And it is from Israel. So I'm surprised.
So please send me a contact or something, and I'll be happy to look into it further.
I will gladly.
Thank you, Dr. Ginsberg. Let's try to get back on track. Appreciate the comment, and we'll do a parallel follow-up on that, Dr. Ginsberg. So I'd like to welcome Tim O'Malley, who's president of Early Sense. Tim, you want to tell us about what you guys are doing and how it's helping deal with COVID-19?
Be happy to. If I can just share my screen, I think you guys have to unlock that function again.
Lisa, you got that?
While we're waiting, I can start. Early Sense started in Tel Aviv. 3 of the 4 founders of our company had children with asthma, and they wanted to develop a method to detect earlier the asthmatic attack from becoming acute. And they developed a way to do this by putting a sensor underneath the mattress of the child, but not touching the child, and then being able to monitor the respiratory patterns from the child and determine through this rapid and constant monitoring when a respiratory cycle was turning to the point and indicating that it could become acute. And this was about 14 years ago that the founders of the company started to work on this. Can you see my screen now?
Yes.
Richard? Okay, good.
Yes, yep, I got it.
So this was about 14, 15 years ago. They decided that it wasn't enough to just focus on that capability, and they really went back and developed the system to become more of an overall deterioration monitoring product, and a product that would help and allow to monitor patients that were typically not monitored, either in a hospital setting or outside the hospital setting, and be able to give these updates on the cardiac and respiratory cycle in a very rapid fashion, and also to be able to monitor motion from the patient, because all of this data coming through our sensor, which again doesn't ever touch the body, we're capturing motion signals from the body, and the algorithms are interpolating that as either a cardiac cycle, a respiratory cycle, or gross body movement. And so the product was launched into the US market in 2013 with the goal of helping hospitals put it throughout their hospital wards, general floors, med-surg floors, to monitor patients that otherwise weren't monitored except on the occasional rounding basis. And we've since signed an agreement with Hillrom who's the biggest hospital bed company in the market. So every Hillrom bed today in the med-surg environment has an early sense sensor built into it. And so we wanted to offer this protection for patients that were typically not monitored or needed to have more acute monitoring around things like a bed exit and an unsupervised bed exit to hopefully prevent things like falls from the bed. It's currently used, the product is used in over 250 facilities. There are over 50,000 sensors of ours in beds today active across the world. And in Florida, you could see on the bottom left side these arrows. This was data that was compiled from one of our customers in Florida, which it happens to be a VA medical center in Central Florida. And they deployed about 125 beds of early sense and saw dramatic reductions in things like code blue activations, which, you know, in a hospital setting, a patient that experiences a code blue event has a very, very poor survival chance, even in the hospital setting. And from this, they were able to reduce those code blue events by 50%. And the associated mortality with the code blue events by over 80%. And so needless to say, we are pretty active in VA medical centers across the country today in the US, and as well as in the state of Florida. Rewind back 60 days to the pandemic of COVID-19, contact-free monitoring, as Dr. Regev said, that, you know, contact-free monitoring being used at Sheba Medical Center. It offers a huge benefit because there's no leads or sensors that are on the body. Everything is measured through the mattress in a contact-free situation. And so you really have minimized cross-contamination. You've minimized the need for staff to go into the patient's care area on a very frequent basis to readjust leads that might be on the body or electrodes that might be on the body in a more traditional way. And you can actually display and show the monitoring data outside the patient's room. And so it further minimizes the need for staff to have to regown and redress to go into an isolation area like a COVID room to address some of the equipment problems that occur with more traditional based monitoring. And how the system works is it's a sensor, as I said, on the left side here that goes under the mattress and sits on the bed frame. And through the mattress, the sensor will absorb the vibration and motion that's generated from the body. And we will then display either on a bedside unit, like you see on picture number 3, we'll display some of those parameters there on the bedside unit, or in the case of a COVID patient, you might see a device like number 2, which is collecting and processing signals and pushing those signals to a remote display like this. And so with this kind of a display, you could see dozens of patients on one screen, and you'll get all the necessary alerts that you may need in order to tend to those patients. Some of these might be that the patient is out of bed, and you can see, like on the one bottom red line there, it says chair exit. And so it's indicating that the patient has actually gotten up out of the chair and, you know, is moving around from the chair. If it's not a high fall risk patient, it doesn't really need to be addressed right away. If that patient is a high fall risk patient, we can set the sensitivity for that very tightly so that you know essentially when they begin to leave the chair or try to leave the bed, not after they left the bed, which is important. There's also a lot of algorithm work that's been done here. And so, for example, if you look at a patient that might be seeing a change occurring to heart rate, respiratory rate, or respiratory patterns, and if the system detects those changes are occurring and are sustained for a period of time, it will indicate that this is potentially a patient that you want to look at and measure for other things like infections or early signs of condition called sepsis, for example. And we've seen COVID patients, obviously, out of Sheba. This happens to be a case study that was done at a long-term care facility in Illinois. We've all heard the terrible situations in these facilities. I will say that there are many of them that are actually performing very well. And this happens to be one where they actually, if you look at the blue line on the screen, you can see that that patient's respiratory rate was down around 12 to 15 breaths per minute. Started to climb up shortly after 8 o'clock in the morning. And again, from a patient deterioration perspective, there's this magic 6 to 8 hour window that you look for to determine that the patient is potentially going to be in trouble if the trend continues. In this particular patient, that trend did continue. And as you could see, by 12 o'clock noon, this patient was generating respiratory alerts for the caregivers so that they could actually go in and assess what was happening to this patient before it became a highly acute event. This happened to be a 58-year-old male. As you could see, they had a host of things that were going on with them. They were COVID-19 positive, and because of what was done with our trending of the respiratory rate, they were able to give treatments there locally for this person and allowed them to stay in their facility to be treated for.
Tim,
More
let's
than
try
just
let's try to bring it to a
wrap it
close.
up.
Yep.
So we also monitor more than just COVID patients. It's an example of a cardiac arrhythmia patient, very high heart rates, again, treated and prevented a code blue event, which again is catastrophic. Thank you.
So I'm curious, Tim. One of the sort of barriers that you have to overcome is the challenge of integration. So how hard is it to integrate the hardware into a hospital room, into a hospital bed? And then, what about the data? To what extent do you integrate into the EHR, et cetera?
Yeah. So, the system does integrate, as I said, into Hillrom. And so we're a part of that bed because, as you state, people don't want to have separate systems. They want to have things all together. And so
Right.
being part of the bed allows you to do that. We also have the ability to push all of our data out into EMRs, other devices like mobile communication devices and platforms. And we have done that in a number of cases.
Good, fantastic. I'm not sure we have any other questions. I think that covered the one, and we're running a bit behind. So if we can, Tim, thank you very much. It looks like exactly, the kind of contact-free technology that can, isolate the patient and protect the healthcare workers tremendously. So, boy, has that message, I think, come through to all of us around the world, how important that is. So thank you. I'm going to turn now to Adam Devine. Adam is the CMO at Innovating. So even a sort of more advanced, more futuristic, if you will, use of computer science and information technologies. Adam, you want to tell us what Innovating is doing?
Sure thing. Thank you, Richard. Tim, could you just unshare so that I could share my screen, please? Thank you. So first of all, thank you, Richard. Thank you to everyone who's joined. Thank you particularly to Dr. Regev. We really appreciate all of your support. I think you guys picked two really interesting companies to profile, one that's actually directly impacting patient health, and another one, ours, that is helping to protect staff and individuals from exposure. So the technology that I'm going to take you through is called computer vision, and many of you guys in radiology, I'm sure, are very familiar with computer vision. The three applications I'll talk about are touchless entry, contact tracing, and telemedicine. So let's dive right in. First, again, thank you for everyone who's joining. I know everyone's busy. I'm hoping that I can present you with a solution that you can take back to your organizations to protect your patients and to protect your staff. The second thing is focus. I think this situation has caused every business, every medical facility, every individual, every family and every technology company to think about what they can do to protect and enhance the safety of the people and things that they care about. And we did just that at AnyVision. We thought about how our fairly vast computer vision capabilities could distill into a handful of products that would really make a difference in this pandemic. And those are the three things that I'm going to talk to you about today. So in terms of what we've learned through our collaboration with Sheba, which I'll also talk about, we've learned that there are really kind of four major challenges as we see it from our perspective. The first is to protect staff. We hear a lot about, medical providers becoming infected and, going out of duty and in some cases losing their lives. We hear a lot about the risk of exposure, being able to identify who is likely a high risk and who they've come in contact with. We've heard a lot about the increased friction with increased throughput at care facilities. Naturally, there becomes more operational friction, and that can get in the way of the quality of care. And then the last one is continuity of care. Once someone has been discharged from a provider, it's important that they have a safe way of continuing that care relationship, particularly as capacity at hospitals are at their peak right now. So I want to define for everyone who isn't familiar with it exactly what we mean when we say computer vision. So when we think about human sight, right, it's limited basically by four factors. One is the focal point. We can only see what I'm sorry, was someone trying to talk? If not, could you please mute your line? Thank you. We're limited by our focal point. We can only see what's in front of us, what we see through our own eyes. It's limited by fatigue. People get tired, they have to sleep, they lose focus, literally and figuratively. And also by the inability to remember everything that is in front of the field of view, and also bias. So what computer vision does is eliminate each one of those limitations in human sight by allowing a software and thus a person to see and connect the dots from multiple sensors. So imagine if you had eyes on an entire hospital, you could combine all of that data into one point of view and connect the dots. And it's also 24/7. There's no challenges with accuracy. And importantly, if it's trained correctly, these algorithms are free of bias. So these leading organizations that we're working with, both in business and in terms of healthcare providers, are seeking to eliminate the need to touch surfaces upon entry. So in many cases, you have turnstiles, gates, doors, ER doors that are, and touching those points of entry, you can hear New York City in the background here, touching those points of entry presents a risk of exposure. The second one is increasing the security around people and premises. So being able to identify threats, whether it's a COVID carrier or just is really important. And then the third one, as we talked about, is being able to provide those secure services on a personal device. So for each one of these challenges, there is a distinct computer vision capability. The first one is touchless access control, and then there's watchlist alerting for perimeter control, internal security and contact tracing, and remote authentication and verification for example, telemedicine. So this video kind of sums up everything that we do and everything that we stand for right now.
From mankind's biggest challenges have come our biggest advances. The unity and speed of how the world responds to threat has left a legacy of breakthroughs that have made life easier, healthier, and safer. New threats to our safety call for us to rethink how we move through the world, how we connect with one another, and how we protect what's important. Computer vision has helped us interpret the world, and now it helps us ensure its safety. The risk of surface contact and the need to control who goes where calls for touchless access control that uses face recognition to open secure points of entry. Heightened perimeter risk and the need for accurate contact tracing calls for automated watchlist alerting with privacy protection. Securely moving services from physical spaces to personal devices calls. AnyVision provides these capabilities, each born of the same world-class research ethical rigor, and proven artificial intelligence technology. As we work towards a new normal, organizations of AI-driven computer vision will ensure a safer, better protected, and more connected world.
So there we have it. That kind of sums up our purpose right now. And that last image always moves me, thinking about hugging my parents again. I think we all miss that. And hopefully we get to a point very soon where we can do that again safely. So let's double click on touchless access control. Again, what that means is in the old world, there were means of getting into a secured space or a room that required touch, turnstiles, fingerprint IDs, keypads. Those days are over, no more. What we can do now is use someone's face that's uploaded into software to identify someone who belongs in that space and automatically open the door. It's as simple as that. The next one is automated watch list alerting. So what does that mean? It means that in the old days, and still right now, you'd have very highly trained security people, or in the case of contact tracing, epidemiological nurses looking at screens, calling people, trying to figure out who's who, and identifying threat manually. And that's unfair, and it's frankly impossible for people to do. It's too complex, there's too much data, and there's too much reliance on human fallibility. So what we have now is the combination of those talented people and software that automatically identifies someone who is on a watch list, whether they are an organized criminal in retail or if they're a known COVID-19 carrier, and alerts the person who's behind the controls and identifies the people with whom they have had close contact over a period of time. So I want to talk about contact tracing. There's two fundamental problems with the way it's being done right now. On the left, the manual way of doing it, it relies on memory. And when anything relies on memory, there is fallibility. You've probably heard a good bit now about how Apple and Google are doing contact tracing, how big tech, so to speak, are doing it. That's fallible as well because it relies on people who are uploading an app to their phone and also opting into a program. And sure, it's likely that given the severity of this pandemic, a lot of people would do it, but not everybody would. And if you don't have 100% compliance, then you don't have 100% accuracy. So, this just kind of underscores the problem here. Wired reported on it, allows users to opt in to Bluetooth-based proximity detection scheme when they download a contact tracing app. So built into that observation are variables, and that compromises the integrity of contact tracing. So a quick video again to explain how contact tracing works with computer vision.
Public organizations are working to slow the spread of the virus by identifying people who have come in contact with known carriers. Facial recognition software can be paired with existing camera infrastructure to draw out the path of previously identified carriers of the virus, identify the people they came in contact with, and create a viral exposure graph. The system sends real-time alerts when people who were potentially exposed are identified so that public health officials can notify them. The system also blurs the identity of people who are not recognized as known carriers or potential exposures.
There we have it. So, Dr. Regev was kind enough to talk a little bit about how they're using our software. And I want to underscore that it's a combination, right? So you have experts who are at the helm of this software who know what they're doing, and they're using technology to augment their efforts. And I think that's true of technology in general. You can't have 100% automation. There's always going to be a human in the loop to maintain ethics and to maintain the right practices and procedures. If you want to learn more about what Sheba has done with our product and some other things that they talked about, there's actually a webinar that you can see on Facebook. If you go to facebook.com/Sheba, MC, which stands for Medical Center, and ENG, which stands for English. So it's a really interesting presentation. It'll give you some more perspective on this. Very briefly about remote authentication and verification. Again, we've all been to a bank, we've all been to a doctor's office. Hopefully we'll continue to do that in the future. I'm sure we will. But until it's totally safe, it's really important that we be able to authenticate someone's identity, which eliminates the risk of digital fraud and any kind of wrongdoing in a really seamless, easy way for the patient. So a person literally just opens up the app. In this case, it would be Sheba Medical Center or any number of different organizations. Our software development kit, SDK, automatically authenticates the person's identity without making them do all kinds of weird things in front of the camera. And then they have a secure connection with the service provider. Super simple. So just to kind of sum up what we are doing to help providers reduce the risk of infection and enhance safety. For each one of these risks here on the left, there is a capability. Starting from staff exposure, we're able to provide a capability where care facilities can set up digital quarantine. So anyone who breaches a certain area, there's an alert that goes off. We're able to provide automated watch list alerting, which is kind of the macro category in which contact tracing sits. We're able to eliminate the need for people to touch surfaces to gain access, authorize access to controlled spaces, and we're able to authenticate and verify patient identity for secure provision of care. If you have any questions at all, I'm sure we won't have time to get to all of them. Please feel free to reach out to me personally. You know, part of my job is being a professor. I'm happy to answer any questions. I'm happy to put you in touch with our commercial team if what you saw here today is a good fit for your organization. Richard, thank you.
Super, thank you, Adam. And it's quite amazing technology. I wonder if we might just discuss a little bit. You know, so to what extent does a person still have to opt into this approach?
So that, you know, it's an interesting question that really depends on the procedures of an organization. So with Sheba, they all, you know, everyone within the facility opted in because they wanted to protect their own health. You know, they had 10,000 people there, so all of them kind of ticked the box and said yes.
Right.
You know, we would like to see a universal use of this technology. And in the same way someone is asked to download an app and opt in once they've downloaded the app, we'd like to see entire governments use this technology to protect their citizens. But there does need to be opt-in based on GDPR and other local regulations. But you know, technically, anybody could use it.
I mean, it seems like, you know, you're really smack up against whether it's GDPR, but just generally have we unwittingly created this massive surveillance state? And it's like the technology is extraordinary for what it can do, but at what price? And it just must be fascinating to be working at that cutting edge, trying to make sure that you get all of the very real tangible benefit of the technology while being respectful of privacy. So it's cutting edge in many different edges.
Indeed it is, Richard. I think one of the most important things that I would like to be able to communicate is that our software automatically blurs the faces of everyone in front of the cameras who are not on a watch list. And importantly, modern technology, ours included, unlike previous generations of facial recognition, it turns faces into mathematical vectors. And that means that it's impossible to figure out who is who once it's been turned into a vector. So you have two ways of totally preserving the privacy of the public.
Right. Interesting. Thank you so much. Thanks to both you and Tim. You know, we're run over time, but I think it's been you know, a fascinating discussion. I think either you know, our two physician experts, Dr. Abbo and Dr. Regev, could have gone on for an hour and a half, or we could, you know, be digging into innovative technologies such as those from AnyVision and EarlySense even more. And things like COVID-19 really highlight, if you will, the good news of the modern age, and that is that we have, you know, a variety of technologies which we didn't even necessarily think of contributing to the pandemic and future pandemic management as we do today. So let's all hope that we can stay safe as we work our way through this one, and that innovators like EarlySense and AnyVision and others, both in the US and in Israel, can come together to help Dr. Abbo and Dr. Regev. Any other comments from Beacon Council or the Israeli Consulate? Greg?
No, just wanted to thank everyone for who spoke today and everyone who came out. And this was really, I hope everyone found it as fascinating as I did. Thank you so much.
Very good. Many, many thanks, everyone. And don't forget, Beacon Council contact info and Israeli Consulate contact info is in the chat. So before you quit, you might want to grab those links or email addresses if you want to follow up in any way.
Thank
All
you
right.
for all the presentations. Very nice. Thank you.
I'm glad you enjoyed it, Ariel. Thanks for participating.
Thank you.